Abrar. Dr. Sehrish Abrar is a consultant radiation oncologist at Khan University, Karachi. She completed her training in radiation oncology at Khan University in 2018. Her clinical areas of expertise include gynae, breast, gastrointestinal, and skin cancers. Dr. Abrar has been actively involved in education and teaching to residents and radiation technologists at all levels. Her research interest includes gynae oncology, re-irradiation outcomes, radiomics, and clinical audits. Dr. Abrar is coordinating the RO Research Forum, and she has published manuscripts in national and international journals. She is a part of Irish, Turkish, Canadian, and Italian professional development exchange programs. She is the chairperson of Rectal Cancer Study Group in Pakistan. In addition to these, Dr. Abrar has been involved in developing departmental treatment protocols for pelvic malignancies, leading and coordinating site-specific multidisciplinary teams inside and outside Pakistan. Dr. Abrar, please.
Assalamu alaikum, everyone. I'm Dr. Sehrish Abrar. I'm a consultant radiation oncologist in Khan University Hospital. Can you please put up the slides? So today I'll be talking about the organ preservation in the rectal cancers, when, why, and how. A very nice discussion has been made in the previous session. I'll be touching upon many of the similar points in my presentation. So the outlines of my presentation are the organ preservation in the rectal cancer, when, why, and how we can offer the organ preservation. So first of all, I would like to define the organ preservation. The organ preservation is defined as when the rectum is intact after the treatment and the surgery in the form of TME is not being done, and if the patient have the locoregional regrowth that is salvageable by the local excision. When we can offer the organ preservation. So we all know that there are many studies where the neoadjuvant concurrent chemoradiation therapy is being done in the locally advanced rectal cancer patients, and we see the pathological complete response in more than 15% of the patients, especially in the locally advanced rectal cancer. And this number is more in cases of the early tumors. It is more than 40% when we are dealing with the early tumors. So this has been taken from the Astro Clinical Practice Guidelines. In the Astro Clinical Practice Guidelines, they mention that the appropriate indication for consideration of the non-operative management or the local excision approach after the definitive or the preoperative chemoradiation therapy are, it is being done after the multidisciplinary team discussion, and it is only offered to the patient who don't want TME or who would have a permanent colostomy or inadequate bowel continence after the TME. And very, very important point is that that the patients agree to the stringent follow-up. Without the agreement of the patient having coming on the stringent follow-up, we cannot offer the organ preservation. Now, why we may offer the organ preservation? So this is actually the surgical series, and it's a long-term outcome in the patient with pathological complete response after the chemoradiation for rectal cancer. So in this retrospective surgical series, more than 3,000 patients were included, and they all had the pre-op concurrent chemoradiation therapy followed by the surgery. So in this surgical series, they find out that 15% of the patient had the pathological complete response, and in this analysis, they try to see the 5-year disease-free survival. And here you can see, sorry. I'm going forward. Okay, so here you can see that those patients who had the complete response of the treatment, they had the better local control as well as the distant control. They had the better overall survival and the disease-free survival as compared to the patients who were non-responders. Now, again, this is a surgical series, and in the surgical series, a correlation is trying to made between the YPT stage and the lymph nodes in the mesorectum in the patients who had the concurrent chemoradiation therapy followed by the surgery. So 20% of the patients had the pathological complete response in the series, and here you can see that those patients who had the complete response after the neoadjuvant treatment, PT0, they had the chances of the lymph nodes in the mesorectum is very less. It is just 1.8%. And if it is PT1, the chances of the lymph node in the mesorectum is 6.3%. Now I'll discuss that how we can offer the organ preservation. Now, the organ preservation can be offered to those patients who achieve complete response or the near complete response after the neoadjuvant concurrent chemoradiation therapy. So, organ preservation can be offered in the two forms, either non-operative management, which is the watch and wait approach, and the other one is the local excision. In the local excision, it's in the early tumor after the chemoradiation therapy, the transanal local excision is done, and only the mucosal, submucosal, and a part of the mesorectum is being removed with 1 centimeter clear margin. So this is the GRICAR-2 study. In the GRICAR-2 study, they included the lower rectal cancer patients who have the disease within 8 centimeter from the anal verge. The disease of the circumference was 4 centimeter or the less, and they included only the clinical T2, T3, N0, and 1 patients. And all the patients received the chemoradiation therapy, 50 gray radiation was given, and then the response was evaluated. Then the patient was stratified either the good responders or the poor responders. Those who were considered the good responders, they have the complete or the near complete response. They were being offered the local excision. After the local excision, if the patient have the YPT0 T1 disease, they were offered the follow-up for 5 years. And those patients who had the YPT2 or T3 disease, they had the completion TME. Here is the number of the total statistics of this study. That total 145 patients were included, and the 74 patients were being offered the local excision. In the 73% patients who had the local excision, 39 patients had the good response. They had the YPT0 disease, YPT0 T1 disease, and 34 patients had the YPT2 or the greater disease. So in those patients, the further completion surgery was done. So those patients who had the local excision first and then the TME because of the poor response, the total number is 28, and all of these patients had the major morbidity, surgical morbidity issues. So this is actually a negative trial because the patient who received the local excision and the completion TME had the major side effects. After that, the 5-year results of the GRICAR-2 study were published, and in this paper, they discussed the disease-free survival and the overall survival. They talked about that there was no difference in the disease-free survival or overall survival in the patients who were being offered the local excision or the TME. Now I'll talk about the outcomes of the non-operative management. So non-operative management is usually being offered in the locally advanced rectal cancer patients. So we have the retrospective studies and the meta-analysis where this thing has been discussed, and here you can see that in the retrospective and the meta-analysis studies, the rate of the regrowth is 20 to 34%, and the timing of these regrowth is usually 2 to 3 years. So most of the patients had their regrowth in the 2 to 3 years, and almost all of them are salvageable. Now I'll discuss the strategies to improve the complete response. There are different strategies we can follow to increase the clinical complete response. The one way to increase the clinical complete response is the radiation dose escalation. The other way is the chemotherapy intensification. The third method is to increase the timing between the radiation therapy and the surgery. Now, this is the meta-analysis of the 18 studies with more than 1,000 patients were included. And in this meta-analysis, they discussed that more than 60 gray of the radiation were used in the locally advanced rectal cancer patients, and the pathological complete response they achieved was 20%. There was grade 3 toxicity in the 10% of the patients. But in the astroclinical practice guidelines, they categorically mention that the patients who are being offered the non-operative management, better to restrict the radiation dose up to 50 or 54 gray. The reason for this statement was that majority of the series of the non-operative management utilized the radiation doses between 45 to 54 gray, and some studies report the higher rate of clinical complete response with radiation dose escalation, but they are limited in size. And the major reason for not to follow them is that they do not report the long-term patient-reported quality of life outcomes. Regarding the chemotherapy intensification, so this is the timing trial, and in this trial, they included the locally advanced rectal cancer patients. It's a phase 2 study, and they stratified the patients into 4 groups. All of the patients had the neoadjuvant concurrent chemoradiation therapy, and then they want to see the effect of the number of the chemotherapy on the complete response. Like you see in the group 2, they only give 2 cycles of the FOLFOX after neoadjuvant chemoradiation. In group 3, they utilize 4 cycles, and then group 4, they utilize total 6 cycles. And all of the patients had the TME afterward. And here you can see that the pathological complete response was more in the group where the 6 cycles was used. It was 38% as compared to it was a bigger number as compared to the other group. Now, in Rapido study, what the investigators have done, they used the short course regime of radiation. They included the locally advanced rectal cancer patients. They used a short course regime of the radiation and followed by the 6 cycles of the FOLFOX of the CAPOX chemotherapy. And all of the patients had the TME. And again, in this study, you can see that the pathological complete response is 28% as compared to the conventional method. It was just 14%. Now, this is the OPERA study. In the OPERA study, it's a phase 2 randomized control trial. In the OPERA study, the patients had the total neoadjuvant chemoradiation therapy. And here you can see that they took the stage 2 and the 3 distal rectal cancer patients, and they were stratified into 2 groups. Either the patients had the consolidation neoadjuvant concurrent chemoradiation or the induction concurrent chemoradiation therapy. In the induction chemoradiation arm, they utilized the chemotherapy first, followed by the concurrent chemoradiation therapy, while in the other group, they utilized the radiation first and then the chemotherapy. And all of the patients had restaged with the DRE endoscopy and plus minus biopsy. Of course, the MRI was done. Then the response was evaluated, and those patients who had no clinical response, they were being offered the TME, and the patients who had the complete response, watch and wait approach was utilized. And here you can see that there was no difference in the disease-free survival and the distant metastatic-free survival between both of the groups, but around 50% of the patients in both the groups had the organ preservation in OPERA study. So now I'll talk about the timing, how important is the timing to increase the clinical complete response. So this again is taken from the surgical series, and here you can see that more than 95% of the pathological complete response is usually achieved after the 10 weeks of the interval from the end of the concurrent chemoradiation to the surgery. So the timing is very, very important. If you want to increase the clinical complete response, you may increase the time between the surgery and the neoadjuvant treatment. Now, the very important question that how to determine the clinical complete response. So, to determine the clinical complete response in this paper, they categorically mention that we should use DRE, MRI, and the endoscopy. And all of these three modalities combination increases the probability CR prediction up to 98%. Now, an important question that should we do the biopsy of all the patients when we are considering them for watch and wait approach? So the answer is no, because biopsy may give the false negative results. Again, in this is again a surgical series, and in the surgical series, they discuss the correlation between the YPT stage and the residual tumor cells in the different layers of the rectum. And here you can see that in T4 diseases, actually this green line is showing the residual disease in the subserosa, this magenta is showing the residual disease in the muscularis propria. So if the disease is YPT3, T4, the localization of the residual tumors in the mucosa or submucosa is very less. The majority of the residual tumors would be in the muscularis propria or the subserosal layer. The follow-up strategy, a very important question. As we know from the surgical series that the most of the recurrences happens in the first 2 to 3 years. So the follow-up should be very stringent for up to 2 years. Every 3 monthly DRE, endoscopy, and pelvic MRI should be done. And the chest and abdominal CT should be done every 6 to 12 months. And thereafter, the frequency should be less, and it should be done it may be done for 6 monthly. Now, there are many ongoing studies, there are many ongoing phase 2 and phase 3 studies where this watch and wait approach is being investigating. There are Brazilian trial, and there is another trial where the contact brachytherapy is also being used. And in this study, they utilize the brachytherapy to increase the clinical complete response, and they use the 90 gray of radiation dose. They give 90 gray of radiation dose to the patients to achieve the clinical complete response. Now, this slide is about the radiation oncology rectal cancer study group. This group was formed just by our team just to increase the knowledge, or to fill the knowledge gap of our colleagues and to educate ourselves, and to increase our international networking. So the take-home message from my my talk is that we cannot offer this watch and wait approach without having the site-specific tumor board. So site-specific tumor board is necessary if we are offering a watch and wait approach to any of the patient. Thank you.